All right, I gotta open this lesson with kidney stone jokes. All right, so here we go. Why do nursing students dread the test on kidney stones? Because it's the hardest one to pass. Oh, yep. Okay, here's another one. What did the woman say when she finally passed her kidney stone? Urethra! Okay, I think that's funny because I used to say Eureka as a kid, so urethra, Eureka, okay. Okay, what happens if you've got kidney stones? You're in trouble. Last one. Why did the patient name his kidney stone Pluto? Because it was finally out of his system. Oh, okay, you guys, it's going to be a great lesson. I hope you're in for it. And I feel like I'm yelling. Why am I yelling? Okay, I'll put my normal talking voice on. Okay, this is some of the topics I'm going to cover. Pause here if you need to see how I organized your slides. Otherwise, let's go take some practice questions. Read the question, pause the slide because I'm advancing forward. And did you get this answer? A full physical assessment is not needed at this time as the focus assessment has complete data. Complete assessment would not be appropriate in an emergency situation, in case you chose that option. Okay, the hydroureter is a complication that occurs when a renal calculus moves into the ureter and blocks as well as dilates the ureter. Symptoms include severe pain and spasms, nausea, vomiting, and diminished volume of urine. A hydroureter is a medical emergency that can lead to shock, infection, subsequent impaired renal function issues as well. So diagnosis of this condition is needed for immediate intervention. And the last two, those actions are important, but they're not appropriate in an emergency situation. Okay, another question. While you read it, I'm going to click and move forward. Here's our answer. A quadriplegic who was in an auto accident experiences prolonged immobility. This increases calcium loss from the bones and therefore increases the chance of calcium stones to participate in the urinary system. And I did not say participate, I said precipitate. Right. The person with the MI, the diabetic, the patient with UTI, they do not have an increased risk for stone development at this moment. How'd you do on the questions? Good, I hope. Have you known anyone who ever had a kidney stone before? Maybe you don't know of anyone, but you yourself had one in the past? If you had to describe the experience of what you saw, or maybe what you felt in one word, what would you say? Well, for many patients who had kidney stones, the response will be pain. Pain from the urethral spasm is excruciatingly painful. Get that? Pain is painful. Patients can even go into shock from the stimulation of nearby nerves from that type of pain. I briefly want to describe how a kidney stone formulates. So, once upon a time, kidney stones develop, no, I'm just kidding. Kidney stones develop from supersaturation of the urine. Yes, supersaturation. Supersaturation of the urine is when too many particles in the urine collect together and precipitate or develop into crystals. Everyone excretes crystals at some point in their life. However, 10% of patients get stones. Hope you're the 90. So let's talk about the different types of stones. Majority of stones are calcium-based. Less common is the struvite, the uric acid, and the cystine stones. Struvite stones are formed from chronic UTIs. Cystine stones are genetic in the body, are genetic type that form in the body when the body cannot rid cysteine, which is an amino acid byproduct from its system, so a stone forms. These are the only stones, by the way, that are translucent on X-rays, the Sistine kind. Like the Sistine Chapel, you know, it has those very beautiful windows, transparent. Yes. All right, so I've actually got an example of what a stone looks like, so feast your eyes on this. I'm yelling again, aren't I? I need to sit back. What do you think something like this feels like as it moves down the genitourinary tract? Feels amazing. Some causes for stone formation are, here's your blanks. 1, dehydration. This is in fact the main cause for stone development. Number 2, genetics. Genetics will not allow a person to make the substance needed to prevent crystal aggregation, so thereby the stones form. Number 3, having too acidic or too alkalotic urine. Number 3. Number 4, corticosteroids. Yes, prednisone. And I'm not talking about the prednisone where you're on it, 5 days for a upper respiratory infection. I'm talking about you have lupus and you're on it for a long time. That kind of corticosteroid use. Next, number 5, excess calcium absorption from the GI tract. And this could either be excess ingestion, maybe you overdosed on some Tums, or it could be you have some kind of metabolic tendency to absorb too much calcium. So, what do you think kidney stones put the patient at risk for? Well, is the urine flowing out? No, not really. In fact, this is called urinary stasis. What do you know about what happens to static urine? And it's the perfect bacteria environment, right? Exactly. Well, are those kidneys still making urine? Do they know to slow down when there is an occlusion? Answer is no. So not only do we have urinary stasis, but now the urine is continuously being produced within the kidneys and it has nowhere to go. So what happens to the excessive urine? And what are the kidneys going to do about it? That's right, they die. Well, okay, maybe not outright, but there will be infection and possible kidney damage. Right. And then you die. Okay, you don't, but you do in a few days. Okay, some risk factors. Kidney stone development can be a secondary condition too. Say a patient has hyperparathyroidism or a heck of a lot of calcium in their bloodstream. Maybe they have urinary tract obstructions from BPH and they have urinary stasis. Maybe there is prolonged immobilization, not from being a paraplegic, but they just are in bed all the time. Maybe there's inflammatory bowel disease such as Crohn's or ulcerative colitis. Those can actually lead to development of kidney stones. But I will say this, if we take care of the underlying condition, we mobilize the person, we take out the prostate or minimize it, the stone risk is reduced. Believe it or not, stones are more common in people who live in the southeast regions. What does that tell you about our diet? They tend to occur more in young adults than older adults and people of Caucasian race. And people who are obese as well. Specifically talking about diet, calcium oxalate stones can occur if someone consumes a diet too high in oxalate. And some examples of foods that contain oxalate are spinach, as evidenced by my Popeye can of spinach there. Rhubarb. If you don't know what rhubarb is, that's okay. You can Google it. It comes from the north. Swiss chard. You can Google that too. Chocolate. Yes, I did just say that. Chocolate and nuts. These are foods high in oxalate. Now, please know this. This is a frequently asked NCLEX question about nutrition and disease management. They always ask about foods containing oxalate, and they always ask about foods that have vitamin K, you know, that whole reversal of coumadin. So your best bet is to remember these 5 foods I have suggested that are high in oxalate, so you can answer correctly on the NCLEX. And you're welcome. You know, some stones run in families, so it's a good idea to determine if these may be the genetic type of stone. So do ask, do they have a family history of stones? Do ask if they've ever had a stone themselves, because having one stone puts you at risk for more. Let me say that in a different way. Ask a person in a general history question if they've ever had stones, and if they say yes, anticipate that they could have develop one more somewhere in their future, so we can cater our education to prevention of stones. Anyway, now if they said, yes, I have had a stone in the past, do ask if they've had a chemical analysis performed on the stone. Sometimes if they're passed at home, they're just discarded, but maybe they passed one in the hospital and we were able to do some testing on it, because testing results equal more targeted teaching. Right. Well, let's also ask them about what preventative treatment did they do in the past. Like, did they do shockwave therapy, or did they just drink tons of fluids and walked around, which is also a non-surgical intervention? Was there med adherence issues? Did they get placed on diuretics like hydrochlorothiazide, which is a preferred medication to help pass stones? Did they alkalize their urine enough? Maybe they didn't drink enough items with citrate in it. Some examples are lemon water, orange juice, to get their pH to like 6, maybe 6.5. Just to throw it out there, it feels completely opposite to me to drink an acidic liquid to alkalize my urine. Okay? I don't get it, but go with it. So you're going to drink acid to have more alkaline urine. That's right. It's because they have citrates. Just go with it. That's what they say. Makes perfect sense. Well, surprise, surprise. A major clinical manifestation is pain. I think you already know that, though. Patients with kidney stones have a very descriptive type of pain. In fact, they call it renal colic. Renal colic is caused by the obstruction of urine, and it is described as unbearable, severe, radiating flank pain. I'm getting worked up. Yep. Now, flank pain may not always be the epicenter of the pain. Okay? It really depends on the stone's current location. So you may have pain in different areas of the pelvis. Patients will often have nausea and vomiting. If you look at their skin, you will notice that they are very pale, or they have pallor. Also note that they are going to be diaphoretic and sweating. And these are responses to the pain and possibly impending shock. The vital sign changes that we're going to notice are well, let's talk about vital signs associated with pain. Let's go there. You're possibly going to see tachycardia, so a heart rate greater than 100. You may see hypertension and tachypnea, a fast breathing pattern. And this is because the pain is affecting them so much that their vital signs have changed. Other changes that we may see if their urine is infected would be tachycardia and a fever. Lastly, if they have developed hypovolemic shock because they're in so much pain, which this occurs, their blood pressure will now drop and they will be tachycardic. Last but not least, we must notice and recognize when there is an obstruction, because this is a medical emergency and we must preserve kidney function. You only get 2, just in case you didn't know. So protect both of them. And to double check a lower urinary tract obstruction, you will see a distended bladder. I kind of threw that in there. even though I'm done with the slide, I just had to sort of mention that. Distended bladder equals retention, and that means the stone is lower. Okay, yeah, good. Oh yeah! How do you like that picture? This does not look like a good situation to me. And if our patient has oliguria, which is meaning scant urine, or they have anuria, which means no urine or absence of urine, anticipate the stone is somewhere inside. Doesn't matter if it's high or low, it is obstructing, and therefore we must take more aggressive measures to allow urine to flow. Let's talk about some diagnostics. Well, believe it or not, your most sensitive and standard way of detecting a stone would be right here. Ooh, this is hard. This is really hard. Good. Okay, that is your most sensitive and standard way of detecting a stone. However, if a pelvic CT non-contrast is unavailable, then you do this one. I got this. Yep, great. We're going to do a KUB, kidney, ureter, and bladder x-ray. This easily detects radio-opaque stones, and it's a good second to a pelvic CT. Now, why do I have renal ultrasound up there? This is a common test as well, and it is useful in detecting hydronephrosis. So, does the kidney have too much urine obstructed inside it, and is the kidney enlarged? We can grab a CBC. We're going to be looking for increased white blood cells if there is an infection present in the urine. Otherwise, the white blood cells, they won't exactly change if there's just a obstruction. But they will change if there is a infection with the obstruction. Let's grab a urinalysis on this person. We're anticipating the pH possibly to be altered, making it that favorable environment for stones. If the pH is low, meaning it's a little bit more acidic, we're going to see a uric acid stone type probably, or cystine stone type. That is if the pH is low. Now let's say the pH is high and the urine is a little bit more alkalytic. We're going to see the possibility of calcium phosphorus stones and struvite stones. They tend to do well in that type of urine pH. Anticipate in your urinalysis to have a lot of blood. In fact, this is due to the abrasions to the urinary liner from the stone in its migration. Would you anticipate to see white blood cells in the urine? That's a maybe, actually, because UTIs are often going to accommodate kidney stones. And same for bacteria. We may possibly see bacteria in the urine. Now, we will see presentation in presence of crystals. That's always good to note on a UA. All right, chemistry panel, last but not least. When I grab a chem panel, or they say a chem 7 or a chem 14, we are going to notice that the calcium may be elevated. Let's just say if it's from hyperparathyroidism. We may see an elevated phosphorus. Oh, I don't know, maybe we're going to see an elevated uric acid if we were to draw that level. Maybe our patient has gout. If these are contributing factors to stone development, we will notice it on those blood screens. I bet you didn't know this, but most stones can pass on their own. I'm not saying the patient's not going to have pain, but they don't need surgical intervention. In fact, if the stone is about 5 millimeters or less, a patient can walk and drink it through their system, believe it or not. However, the larger and the higher the stone, the less likely it is to be passed successfully. So let's try all of our interventions that we know of to help the patient pass the stone without surgery if possible. So what are we going to do? We're going to plan on giving the patient IV opioids and IV NSAIDs on a schedule for about the first 24, maybe 36 hours that the patient is in severe pain. My absolute favorite pain medication that's an NSAID is ketorolac or Toradol. Let's see if I can make it. Here we go. Yeah, ketorolac or Toradol. Toradol is extremely effective, but NSAIDs are unfortunately hard on the kidneys, so there's a little bit of a limitation there. What I'm trying to say is check the creatinine. If the kidneys are okay, we know that they have a kidney stone, but if the kidneys are not, creatinine of like 1.8 or something, you can give ketorolac, and it's fabulous. Also, we don't want to give an NSAID if maybe somebody has the potential for surgery, because NSAIDs tend to allow people to bleed a little bit more. So let's not before a planned time that they're going to get cut. Like they're going to do surgery. Okay, I'm over-explaining again. I'll stop that. All right, next, let's try to give them a thiazide diuretic, such as that hydrochlorothiazide. These are taken with increased fluid volume. So please don't give a patient a diuretic and say, see you later. No, 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 no. You're going to give them the diuretic. That's going to help them excrete the stone, and it's going to help rebalance their electrolytes and decrease their urine pH. We want that stone to come out, so make sure they have tons of fluid and give them the diuretic. It feels a little counterintuitive, but just trust me. If you were to catch the stone, make sure it is sent to the lab for urinalysis. Oh, if you're wondering what in the world is being left on that blank where IV opioids and NSAIDs, that means give it to them on a schedule. Okay, very good. Okay, spasmolytic drugs that we can give to a patient, oxybutynin. Does this drug sound familiar? Maybe it's something that we can give to some patients with BPH. It's a great drug, and it helps anybody who has a spastic bladder, like they pee 40 times in a day. However, if there is a total obstruction present, this would not be a good idea, because it will definitely not allow the bladder to let urine out. So oxybutynin is good in the case that a person has spastic urine stream. I said spastic. Okay, spastic urine stream. So always think about before you give oxybutynin. It's a yes in some cases, no in others. Okay, allopurinol. If we find out that from their blood work their serum uric acid is elevated, then it would be appropriate to give this patient allopurinol, also known as Xyloprim. This is going to lower their levels down and decrease the chance that they're going to have stones, more stones. And this is my time to move down there. Always strain the urine and teach patient to monitor for stones. So always teach them to strain the urine and to monitor for stones. Because once again, we want to catch it and send it for urinalysis, stone analysis. Our patient needs to consume about 3 liters of water per day, if not contraindicated, in say a patient with heart failure or maybe even renal failure. Now, our patients with struvite stones need cultures. They need cultures of their urine a lot. In fact, we are going to do it monthly times 3 occasions. Then we're going to do it quarterly, meaning 4 times a year, just for 1 year. Okay? So that's what you need to do for struvite stones, because those are from chronic UTIs. Make sure there is accurate isonos. I can't emphasize this enough. Communicate to your techs everything that is coming in and everything that is coming out should be recorded and measured. Aim for pale colored urine. That's what you're going for. I would say sunshine yellow number 2 if you were picking out a paint color. Yeah, maybe number 3. There is a there's a really high chance our patient is going to have a UTI accompanied our kidney stone. So plan on giving the patient antibiotics as scheduled. There are some popular ones that are listed in your book in a table. We can give some penicillins. Hopefully there's no penicillin allergy. Ciprofloxacin is a very popular one. The other name for that is just Cipro or ciprofloxacin. The big thing about, well, I actually have teaching of the antibiotics in another slide, so I'm not going to really go into that. But let's just pretend that our patient doesn't have the normal, say, calcium oxalate stone or maybe the calcium phosphate stone. Let's just say they ended up testing positive for a struvite stone. Well, for this patient, I'm not going to just give you antibiotics in the hospital, but I am going to insert or have a special central line placed called a PICC line, and you're going to go home on antibiotics. Yep, you are going to go home on antibiotics because you definitely need to prevent more struvite stones from developing. We always want to make sure before we start antibiotics to do a culture and a sensitivity so we have appropriate antibiotic administration. To prevent further obstructions, usually if patients have 2 or more stone episodes a year, they will put them on long-term meds for life. In fact, one of the popular ones are hydrochlorothiazide. And if it's a uric acid stone, you will get allopurinol for life. Oftentimes, we will put patients on statin drugs. I know, statin drugs are for high lipids, but they may be able to help prevent stone formation. Here it is again, that lemon or orange juice. If they have stones that are grown, say in alkalytic urine, calcium 1 is for example. Nutrition therapy. Well, we are going to, depending upon the stone, make those type of recommendations. So we're not going to ask them to like totally avoid calcium, but it needs to be in moderation, and we're going to probably consult a dietitian to assist with this. So they need to look at calcium and vitamin D in moderation. If a person has a stone and they have excessive vitamin C, so we're going to make sure they don't have excessive vitamin C intake because that can lead to stone and crystallization of the urine. You guys know to increase their water intake to about 3 liters per day if not contraindicated. People need to walk, they need to move, they need to exercise. This is what is going to help not only prevent stones and calcium loss from the bones, but it's going to help move the stone along the track if a very teeny one does develop. Believe it or not, you are going to do anxiety management. Patients have, because it's such a horrid experience, a little bit of PTSD. That if they get the inkling that they are having another kidney stone, there is a lot of anxiety associated with that because they know they're about to have a really horrible couple of days coming up in front of them. So let them know what to expect and what actions to take to try to manage it when it comes. There's going to be a couple surgical interventions that can be done with our patient, and it really kind of depends on what the stone is, the patient's size, the patient's tolerance, underlying health conditions, like we do want to put them under surgery or we don't. A lot of times we can do a combination of these different surgical interventions. So it's not either or, but it's what's combination would be best. Which I think I forgot to mention it on the last slide. A big limitation of doing lithotripsy is a person's body mass, meaning if they are of so many kilograms in weight, they would not be eligible participants for lithotripsy because the shock wave will not have enough energy to safely go through somebody's skin. I mean, we can crank it up, but sometimes you don't want to crank it up. So it wouldn't be effective for our morbidly obese patients. It's a limitation of lithotripsy. Right, you got it. I know. Okay, so let's look at stenting. Stenting is usually done under conscious sedation, and what we're going to do is put the patient to sleep, and then we're going to insert using a cystoscope a little thin tube. In fact, I've got a picture of it right here. We're going to insert a little thin tube up the ureter, and this is going to allow urine to come on down so we won't have an obstruction. And what's great is that a stent prevents the stone, which is going to pass through it, to come in contact with the ureter lining. And it's going to minimize our damage to the lining. It's going to reduce pain, our bleeding risk, our infection risk. So a lot of times we will place a stent, and the stent will stay in about 2-3 months or so. A doctor can remove a stent in an outpatient setting, say at an office, and they actually don't put you to sleep to remove the stent. Right. If a person is having this done in hospital, oftentimes we will insert a Foley into the patient. This will also facilitate the smooth passage of urine. Okay, retrograde ureteroscopy. This is where we're going to use a scope with a little basket and forceps, or maybe even loops, to snatch the stone. And if we are up there, we might as well perform the lithotripsy as well, probably using the laser to help break up the stone and to get it so small we can just snatch it out. For the patients who are having the retrograde ureteroscopies, do know that we are going to place a Foley after the lithotripsy is done, and we're going to monitor, well, I'm going to talk about things to monitor in just a second. All of these lovely things here to monitor. Okay, another procedure we can do is a percutaneous ureterolithotomy, or a nephrolithotomy. This is actually one of my favorite procedures that I got to participate in when I worked in interventional radiology. So what we would do is we would use general anesthesia generally to put a person under. They would lay, we flip them over prone so they're laying on their stomach, and we would actually go through their skin with a needle first, and then we'd use dilators to the size of finally getting our scope in, and then we would take a scope and go through the back of their kidney and try to break up the stone with using our laser. In fact, I have a picture of it in just a little bit of what it looks like to prep this patient for this procedure, and I have a picture of what it looks like when you're looking through the scope. Now, after a percutaneous ureterolithotomy is done, we are actually going to leave a nephrostomy tube in place. So the nephrostomy tube stays in. This is going to allow the urine a place to escape in case there is swelling, and it's going to allow the stone to exit out the little fragments through the nephrostomy tube as well. Okay. Let me actually clarify. This is when we go directly into the ureters. This is pretty much the same procedure, but the termination spot is in the kidney. Now, let's talk about nursing care, because this is important. This is testing material. Well, it's all testing material. I know, but this is important. Foley is a yes. These are not contraindicated, but indicated in any of these procedures. We are going to see bloody urine for about 24 to 48 hours. Nobody freak out. Nobody call the doctor. You know you're going to see bright red blood in that Foley in the nephrostomy drain for 24 to 48 hours. Now please do watch a CBC to make sure it's not too much blood and they're going to go anemic on you. It's really minimal, to be honest, their blood loss from these procedures, but I will see when you see bright red urine, it's a little scary at first. We are going to always be checking every shift for bleeding at the site and around the tube. Look for a pneumothorax because there is always a chance that we poked through and went into a place where we shouldn't have, and monitor for signs and symptoms of infection. Patient education is huge, so do make sure to explain prior to surgery how this is going to go, when they're going to wake up, when they're going to anticipate clear urine again, what they will see, what they will hear. This is a very scary procedure for them, especially if they're experiencing all this pain. The patient will need to be NPO prior to surgery, and then when they come out of surgery, it's not uncommon for a patient to resume a clear liquid diet and they progress as tolerated. We are probably going to have to do a bowel prep regimen prior to the procedure, and the reason being is, as you'll see in a picture in just a moment, we are going to use fluoroscopy, which is moving x-ray, and we're going to use fluoroscopy to see where we are trying to locate the stone and if it's all out, and if we have a whole bunch of stool in the way, our x-rays are not going to be as clear and we may miss some little smaller stones. So let's clear their bowels out and do a good old bowel prep prior to. Their fluid intake needs to be increased, and let's just say if they are not taking fluid in by mouth, what are you going to do? Awkward pause. Right, you are going to start IV fluids. Good, because I know that's what you said. All right, what are we going to teach? Yes, it is. We're going to teach to avoid dehydration before and after the procedure, and some specific dietary changes. And once again, it really depends on the type of stone. A good recommendation is to increase their veggie intake, their fruit intake, but careful on the veggies: spinach, Swiss chard, rhubarb. We want them to have a balanced intake of calcium, of fats, of carbs, and low on the protein. We're going to learn in the renal section why we would like our patient with urinary and kidney issues to have low protein, but right now, just go with it. Protein is hard on the kidney when the kidney is a little bit injured. So, no. Okay. Here's my picture of a percutaneous nephrolithotomy, and here's the doctor. Oh, my little things are in the way, huh? Yep, there you go. How about that? Good. Doctor is looking at a scope. The patient's head is probably, your guess is as good as mine, and it looks like they are going through the penis, if I am guessing that correctly. Then this would not be a percutaneous nephrolithotomy because we're going through the penis. Enjoy the picture. Last but not least, this is what it looks like in the procedures that I've been in where we do a percutaneous nephrolithotomy. You can actually see that they are zapping the stone with that laser, and here they're using a snare to snatch whatever is left. This is a very, very cool thing to participate in. That is it. That is all I have. We are all done talking about kidney stones. Let me know if you have any questions. Otherwise, have a great day.